at this point, it seems to me like you have a super duper complex care management program focused on diabetes. The visual part of it, the video, I'm not sure how well you're using that to help your diagnostic aims, or if they're going to be looking at somebody's skin or having them show you a lesion or an ulcer or something like that. So is this a sort of a stage of development issue that will continue to be built upon?
Yeah, I think eventually I think Video Connect or something similar to it is going to take the place of our home telehealth product, so that we will have many different peripheral devices that will be used as part of this. And it's really the two-way video that was lacking in the home telehealth program. Yes.
Can you say anything more about your partnership? I know you've not signed the contracts yet with the post office, because we thought, at Kent Mason, we thought about doing pop-up clinics and things where we could video, we thought about shopping centres and things, but there's licensing issues, aren't there? And there's complexities around the laws. So,
yeah, that's beyond me, actually. I really don't know. I just know that VA was looking into the post office, and they did sign something with Walmart. And I think T-Mobile was offering the high-speed internet. I think Philips or someone was offering technology for the cameras and everything.
Yeah, it just seems in general, although California's catching up, but the technology is way ahead of where the legislation is. I don't know if anybody else has experience with it.
Right. You bring up an interesting point regarding regulation. The VA actually just signed off some regulation regarding providers to be able to have providers be able to provide telehealth services across states lines.
Yeah.
So let me move ahead.
Let's see, Megan stepped out, so I'm sorry.
Okay, so what is the evidence behind telehealth? So home telehealth, the device here, was rolled out about 2003 to 2007. One of the early studies was a retrospective study by the VA in Florida. And basically they looked at previously hospitalized diabetic veterans who were then monitored in home telehealth for 1 year. And what they found was that these patients had a 50% reduction in hospital admission, 11% reduction in ER use, 3-day decrease in bed days of care. They did have greater unscheduled primary care visits, which was something that we thought was good, because basically the primary care was taking the place of the ER. Also, they had improvements of several quality of life measures, such as physical role playing, pain, and social functioning. So this data looked great. It was an early retrospective study, but data looked very, very promising. So then another study done a year later on by Barnett and group, also out of Florida, looked at veterans with diabetes who were enrolled for a little bit longer program, a little longer time. They were enrolled for 24 months. And what they saw was a reduction in overall hospitalizations, reduction in diabetes-related hospitalizations. Again, the numbers aren't as large as the one-year study, but it's still significant. And here they actually mentioned they found a reduction in primary care visits. So Darkins and all, out of central office in DC, they looked at 17,000 patients, VA patients, enrolled in home telehealth. And these were patients that were enrolled for medical and mental health reasons. And what they found is that in 6 months during their enrollment in home telehealth, they had a 25% reduction in number of bed days of care. They had a 19% reduction in hospital admissions. And if we look at the patients who were actually enrolled in telehealth, the age ranged from the 20s to the 60s. Again, the patients who benefited the most were those who were middle-aged and elderly in terms of utilization. And if you look at the reduction of hospitalizations in terms of what areas the patients were located in, again, the rural areas were the highly rural areas was the area that patients most benefited.
How are you getting it out to the highly rural
This is sent out through the mail. This device can be sent out through the mail, and patients can connect this at home.
But they don't have high-speed internet out there.
No, this device is the home telehealth device. This requires a landline or a cell phone. So this doesn't have the two-way video. So if you look at the illnesses where there was a decrease in utilization, hospital utilization, actually the patients who benefited the most were the ones who had mental health disorders, PTSD, depression, and other mental health conditions. Again, most of the patients did have a substantial decrease in hospital utilization who are enrolled in this program, though.
Can you explain a little bit what it looks like for the mental health conditions? Like what?
Let me ask Joe if he could talk about that.
Can you repeat the question?
The question was, what is it like when patients are enrolled into home telehealth for mental health conditions?
Okay, what was your, can you be specific with your question?
So, for example, we heard about what it's like if someone has diabetes and they're sending their blood sugars.
Mm-hmm.
If someone is using telehealth for depression, what are they sending?
It has some questions about with regards to depressions, about the sleeping, about if they have a plan of committing suicide or hurting other patients. And then from there, there are so many questions I can remember what is up in my mind. But let's just say a patient says, okay, I'm suicidal. Right? And then so we contact the patient, we keep engaged with the patient, and if we determine that the patient is truly suicidal, then we contact the VA hotline to give the patients on the phone. And then once they take over, they're specialists for the suicide. That's how it goes. And let's say they have a problem with sleeping. So we do our assessment, we inquire the patients what's the reason why they have problem with sleeping. And maybe medications, issue of concern. And once we determine that, we send a note to the provider. Maybe they can make the changes in the medication. Or sometimes we refer the patient straight to the psychologist or psychiatrist that they're assigned to. So the idea here is we spot the problem, we capture the problem before it gets worse. So that's the point.
So I think mainly it revolves around the disease management protocol. It's less in terms of monitoring, vital signs or anything like that. It's really asking questions with the patient and having the patient respond to your questions on a daily basis.
Has there been a specific form of factor analysis to know whether it's a question of severity or frequency of contact, or what are the drivers of that reduction?
Yeah. I'll talk about a little bit. Actually, many of the studies in telehealth have been done, and there are many mixed results out there. Some facilities have good results, some have not so good results. And it looks like many places, their compliance rate with the patients with their telehome devices is not very high. In some places it's 50%, and many of those places, many of those studies saw not really much of a benefit in home telehealth.
So consistency.
So yeah, consistency compliance with using the device.
Earl, I'm sorry, did you define the unit of measure for utilization in the table?
So this was hospitalization.
It's hospitalization.
Yeah.
And then if someone had, for example, diabetes and depression, did you only count them as diabetic, or did you include them both? How did you, what was your methodology?
I think this, let's see. So I think this counted the main reason why they were in the home telehealth program.
Primary?
Yeah, the primary reason.
So maybe, okay, so there may be some sort of subjectivity there, right? And then the other, in terms of hospitalization, so that include elective and emergent, or just?
It just did count all hospitalizations, yeah.
Thank you.
And then you have 17,000 patients that you analyzed the data. Was that a control group?
No, this was actually a retrospective study. Yeah,
What do you attribute your great numbers to versus the other studies that didn't have so great a numbers?
So one thing about the VA is that telehealth is embedded into our system. We have basically a whole system built in and we take care of the patient, use telehealth as really one of the things that we're doing with the patient. I think in some of the systems, it's really an add-on to what they have right now. The other thing is that the way we do telehealth is we use care coordinators. I think that plays a large role, actually.
Just curious, how many patients to care manager? What's your ratio?
Yeah, it's about 100, maybe a little less than that, about 80 to 100.
For care coordinator, I'm a registered nurse.
Mm-hmm.
For me, for us, 70 to 80 patients, and we ask, we just, as Dr. Saw mentioned earlier, we just opened an L2 low acuity, low intensity patient. For those nurses, it's also manned by RNs, and they will get 80 to 100 patients, because their patients are, for the low acuity, low intensity patients, they only send their data 1 to 2 times per week. So it's not much. Patients need to be very stable on that particular patient that we get into the low, or the L2. We just opened last month. I mean, we just rolled out last month.
Do you have different, is everyone with hypertension in the low acuity, or are there different cutoffs for the?
No, if they have poorly controlled hypertension, they could be in the higher acuity program. So poorly controlled being blood pressure 160 over 90.
Okay.
Excuse me. How are you ensuring that when the patient is measuring their blood pressure, they're measuring it accurately?
Yeah, that's a good question. Very good question. So, Joe, did you want to maybe answer that?
I'll just use some. Yeah. Okay. So, well, this one is an accurate blood pressure monitor here. And so when patients when they check the blood pressure, it goes here and goes to us. Now, before we hand out this to the patients, a lot of times we ask the patient to come to our office, and then we teach them how to check the blood pressure, like pumping the arms, all those things. And once they know that, then this will be used when they get home and to check the blood pressure, not the other blood pressure, the silent blood pressures they have. Most of the patients are familiar using blood pressure, same with the insulin. Because before they get this meter, they go also on a 2-hour class with the pharmacist on how to use this meter. So they're well versed about checking it.
So there's patient education prior.
Yes, there is.
And then do you encourage them to take 1 or 2 readings after, or it's just 1 reading and that's what just goes to you?
Well, let's put it this way. This one can store 500 memories, 500 readings. Initially, when they get the program, when they upload their data inside, it will take maybe a minute, because that's a lot of 500 readings. But the next day, it's just only seconds, 2 or 3 seconds, because there's only 1 reading or 2 readings in there. Like I said, some of the patient, they check their blood sugar. They just say it 4 times a week. I mean, 4 times per day. So this one will store 4 days, and then 4 times in a day. So we advise them that when they upload it at night on the last part of the day, it will show all the readings from morning, noon, lunch, from morning, noon, dinner, and bedtime. Yeah. The same goes with the with blood pressure. If they need constant monitoring, then I advise them to check the blood pressure in the morning, and in the evening, and all those data will be sent in, and then we analyze it.
So maybe we could just hold questions for a little bit. Let me, if we get the finish the presentation, we'll take questions at the end. Or else we'll be here all day.
And I'm sure people will be willing to stay afterwards. It's a wonderful presentation, amazing data still yet to come. And so we'll listen to all your questions as long as it takes, but let's first hear the presentation.
So another review, this is by Trundler et al. They looked at patients being followed in telehealth for a long period of time, followed for 4 years. And what they found was reduced 4-year all-cause mortality, really lower deaths in the intervention group, and longer survival in the intervention group. And here's one of the initial randomized control trials on telehealth in diabetic veterans. There were really 2 arms, home monitoring, which was 1 arm, and then a monthly phone call from a diabetic nurse educator that was considered the standard of care. Baseline A1Cs were similar. Again, these were poorly controlled diabetics. And then the results showed that both groups had an improvement in their A1C, their blood pressure, and their cholesterol However, the home monitoring group had larger decreases in their A1C at 3 months and larger decreases at 6 months. However, most of the improvements did occur by 3 months. And this probably doesn't show up very well, but the top graph just shows an improvement in A1C, that those in intervention group really had the largest increase after a 3-month period, and it was sustained for the 6 months period. They did look at other metrics, weight, blood pressure, really, and cholesterol. Again, they really didn't see any significance between the two groups. So, and then this was another randomized controlled trial at the VA. This was looking at both hypertension and diabetes. And here there were 3 arms. The one was the high intensity group, the low intensity group. Both of these were given a home telehealth monitor, but the low intensity had fewer questions rather than the high intensity had daily questions. The low intensity had less frequent questions. And then the control group. And what they found was that for A1C, the 2 intervention groups had the lower A1C at 6 months. However, they did regress at 12 months. So the A1C lowering effect did not stay with the patients in the home telehealth group. However, with systolic blood pressure, there was a significant decrease in systolic blood pressure at 6 months, and this was maintained at 12 months. And then during the same time, the control group had an increase in their blood pressure. Another thing that was noted that over time, medication adherence improved for all groups. There was really no significant difference. And if we look at the A1C, one of the criticisms of this study was actually that the patients at the start had fairly decent A1Cs. For diabetes, their A1Cs were in the 7s. Again, so the 2 intervention groups had improvement at 6 months, but then had regression in the 12-month period. So if we look at meta-analysis where they combine studies and have a greater power to show that there's a significant effect based upon an intervention rather than something being due to chance, this meta-analysis by Cheryl and al. Looked at diabetic patients followed in telemedicine, and they looked at 42 studies, 6,000 patients. Again, these were fairly poorly controlled diabetics. Their A1Cs were from 7 to 9. And what they found was that those followed in telemedicine had a greater reduction in their A1C. And type 2 diabetics happened to have a benefit more than type 1s, and also that the older patients benefit more than the younger patients. And I think that's something, this fact is something that's seen in many other studies, that older patients seem to benefit more than the younger patients. And again, another meta-analysis, this looked at blood pressure. Again, this was 7,000 patients. This study showed greater reductions in systolic blood pressure, greater reductions in 24-hour ambulatory blood pressure, higher probability that their office blood pressures were also normal, and also found that those in telehealth had greater intensification of their blood pressure medication. It also showed that the number of office visits was actually similar in the 2 groups. So looking at CHF, one of the initial randomized controlled trials at the VA on CHF looked at patients who were just discharged for CHF. They had either 2 hospitalizations, 2 ER visits in the prior year. And the initial thought was that CHF is one of those areas where there was really a high mortality, where monitoring would be a great benefit for these patients. However, what they found was actually disappointing. They did find there was a longer time for readmission, but really there was no effect on readmission rates, no effect on mortality, no effect on hospital days or urgent care use, and no effect on quality of life scores. I think when I reviewed this paper, one of the things that stuck out is that the patients actually followed in telehealth were followed for a very short duration. They were actually followed for only 3 months period. So if we turn to some other studies, actually, well, this shows the Kaplan-Meier plot of the time to readmission, and showing that those in telehealth had a lower chance of readmission, or So looking at one of the non-VA studies that was done, this looked at home telehealth monitoring of the patient's CHF. And again, with non-VA studies, other institutions may do home telehealth a little bit differently than the VA, so some of the results may not actually relate to what we do at the VA, but they actually found a reduced mortality with the patients within CHF and a reduced hospitalization. And actually this was a meta-analysis, so actually the meta-analysis looked at a variety of different studies. There are actually many studies out there that show, some with mixed results, some with good results. Meta-analysis was trying to put everything together and come up with a conclusion, and looking at 3,000 patients, they did find reduced mortality and reduced hospitalization. They said that there probably was fewer bed days of care and probably fewer ED visits. They did not make a conclusion just because based on the heterogeneity of all the studies that they looked at. They did say that also patients in telehealth had more primary care visits along with specialty visits and home care visits. So this is another meta-analysis done in 2018. Again, this did show lower all-cause mortality and lower heart failure-related mortality. This meta-analysis, however, did not show any reduction in hospitalization rates or ED visits. And so going back to the VA, this is a recent just review at the VA, just trying to look at the CHF patients for a longer period of time. These are patients who completed 1 year of home telehealth, and what they found was there was a reduction in days of hospitalization and also a reduction in length of stay for the patients followed in home telehealth. Also lower admissions, however the ER visits and primary care visits were not changed. So within the Los Angeles VA, one of the things that we looked at was hypertension control with our patients. And if we look at the different, we call them PAC teams, primary patient-aligned care teams. We're organized at the VA in patient-aligned care teams where there's one provider, one RN, one LVN, and one clerk all working together as a team taking care of a panel of patients. So we looked at the different PAC teams and how well their panel patients, their blood pressure was controlled, and really it falls under a bell-shaped curve as to the different teams. So we tried to look at those teams which had the best control, and the percentage, so overall the VA has about 78% of their patients are considered to be at goal for hypertension control. The range was about from the 50s to the high 80s in terms of the range of the teams. So looking at those teams which have the best blood pressure control, we came up with some characteristics that those that had the best control had early and aggressive follow-up for medication titration. Often they use secure messaging to communicate with their patients regarding blood pressure readings at home. Number 2, consulting clinical pharmacists to help with titration. Unfortunately, the VA, I think clinical pharmacists are in short supply, so there are not enough to go around, but that is a very useful tool in trying to manage our hypertension patients. And number 3 was using telehealth, home telehealth, using the home telehealth program and using our low intensity program. And number 3 was our Teletuck program. This is a program where our call center nurses will call the patient periodically just to check up on them. They may call them for different reasons. One reason is that those patients who have poor compliance, it may help them with their compliance just to remind them to take their medications on a regular basis. So the conclusion was that those teams that had the best control of their panel patients for their blood pressure, they really utilized as many extended members of the team as possible, used home telehealth, used other nurses, used other staff such as pharmacists.
Could you talk about the ratio of pharmacists on the care team?
So the ratio is supposed to be 1 to every 5 teams, but it's nowhere near that. Unfortunately.
So you need more pharmacists.
Yeah. So it's 1 pharmacist for every 5,000 patients.
So they're pretty busy over there.
Yes. So our teletalk program, this is where one of our call centers, nurses will call the patient during off hours, and these are patients who may need ongoing assessment. They may have been just recently discharged from the hospital or just recently seen in the emergency room, just someone to check up on them to make sure they're doing okay. Some of these patients may need some emotional support, some of those patients who have mental health disorders. Again, some of these patients may need reminders just to be compliant with their medication. And the goal is really to decrease patients coming back into the emergency room or back into urgent care, just trying to increase our care coordination and our quality of care that we give to our patients. So one of the things that we're doing right now with our Video Connect is video home blood pressure visits. And we're using our Video Connect to look at our patients and have the patients take their blood pressure at home to see how they're taking their blood pressure at home, to make sure if they're doing it correctly, and to see what their readings are at home. I mean, often we have patients who bring in their logs or just tell us that their blood pressure is always controlled at home, but every time we see them in clinic, it's always high. Mm-hmm. So this gives us a chance to see how they're doing at home and to basically get a baseline reading of their blood pressure at home. So at the VA, there's really only two ways that we can enter blood pressure data into our electronic medical record. That's if we actually observe the patient blood pressure reading with a VA device, or their blood pressures are directly downloaded. So it really takes the patient reporting out of this this report here. And this was some work that was initially done by the Boston VA, and right now there's a plan to spread this practice nationally for home blood pressure visits through telehealth. So they did look at patient satisfaction with this, and actually the satisfaction was very high from the patient point of view. Also, the clinicians who use this, their satisfaction with this technique was actually very high.
For those who can't read those numbers in the back of the room, can you just brag a little bit more about those numbers?
So from the patient standpoint, prefer home BP checks instead of returning to clinic, 87%. Those patients who are confident in their ability to take their home blood pressure reading, 94%. Those that feel that home BP checks were more accurate than traveling to clinic, 71%. The home BP monitors were easy to use, 96%. Those patients who would recommend a video BP appointment, 96%. Those patients who are overall satisfied with a home BP visit, 97%. And from the clinician viewpoint, those who had confidence in the accuracy of home BP readings, 100%. Those who reported BP video visit was as productive or meaningful as an in-person visit, 90%. Those who were able to conduct video visits as efficiently as being in person, 90%. And those who would recommend BP home visits to other clinicians, 100%. And those satisfied with using video visits to manage hypertension, 100%. So we just talked a little bit about costs. I think for the home telehealth care coordination monitor, I think the equipment itself costs about $1,000 to $2,000 per year per patient for that. I think the peripherals costs a little bit more than that, about $100 for each peripheral monitoring device. So there was one study done at the VA by Barnett et al., and they looked at, this is a retrospective study, they looked at the quality of life gained by home telehealth. And what they did was converted quality of life data into quality adjusted life year. And they used this to look at cost before and after the use of telehealth. And what they came up with is that each year of quality of life gained was costing about $60,000. And this is well within the range of commonly accepted quality of life years gained of $50,000 to $100,000 that's used in healthcare. one of the things that I mentioned is that